I'm sure people will be coming in as we get started. I know everyone has a pretty busy schedule on Fridays. That's usually how it goes. So I just want to thank everyone for making it to our third session of our Food is Medicine Summit series. If you were here for the first two, you can attest to the fact that a lot of great information was spread, and we're going to continue that effort here today. If you haven't been on any of the other calls, my name is Terrence Hunter. I'm the Mississippi Delta Fellow with Delta Directions Consortium, and I'm here to moderate this today's Food is Medicine Summit. Today we'll be hearing from our Harvard partners, and they're going to give you a presentation on mainstreaming produce prescription programs in Mississippi, whether it's on the state level or the local level. As we get started, I just want to have some housekeeping rules put out there. If if everyone can keep their microphones on mute, that would save a lot of confusion and extra noise. We're going to have a Q&A session after the presentation. So as you are listening to the presentation, please feel free to drop your questions in the chat box. We'll get to them when we get to the Q&A session. And if you write them down, please feel free to let us know that you have a question and we'll get to you. We'll be giving you some information on some upcoming series, upcoming summits that we're going to be having as the months go by. But you have to stick around for that information. But so we don't waste any more time. We're going to go ahead and jump into our presentation today. We'll be hearing from Emma Scott, Katie Garfield, and Bridget Slater. So I won't butcher their introduction to their presentation. I will allow one of them to go ahead and kind of give you an overview of the presentation before we get started. So Emma, I think you'll be handling the presentation, so I'll turn it over to you.
Great, thank you so much, Terrence. And apologies in advance if there are any snafus. I've had some internet issues this week, so I'm calling into a webinar for the first time today, and I'm hoping my phone serves me well, and I've seen it work for lots of people on here before, so I'm pretty confident in it, but apologies in advance if there are any hiccups. So my name is Emma Scott. I am a clinical instructor with the Food Law and Policy Clinic at Harvard Law School, and I'm involved in the Delta Directions Consortium, both on behalf of our clinic and on behalf of our students who have a practice organization at the law school called the Mississippi Delta Project. The Food Law and Policy Clinic is also a part of a broader center called the Center for Health Law and Policy Innovation. And that is where I have my colleague, Katie Garfield, who works a little bit more on the health side of our center and is one of the clinical instructors for the Health Law and Policy Clinic. And then we also have one of our star students, Bridget Slater, who is here with us today. Some of you may have met her previously. She joined some of our Delta Directions work over the past summer when she interned with the Food Law and Policy Clinic. And now she's back with us this semester and helped us put this presentation together today. So without further ado, I'm going to share my screen with you all and start talking a little bit about what mainstreaming produce prescriptions looks like. So today I'm going to start by introducing produce prescriptions, which we've had a little bit of an introduction to already. I think the first of our summit, Dr. Annie Kafer and Dr. Megan Rosenthal talked about some of their produce prescription work. And so we're sort of continuing on that trend, but talking a little bit more about the policy side rather than the implementation side. So I'll talk a little bit about produce prescriptions, and then I'm going to give an overview of a policy strategy report that we just published last month in March on mainstreaming produce prescriptions, really on the national level. But then we're going to transition into talking about what the lessons from that report and that research look like for mainstreaming produce prescriptions in Mississippi. And then at the end, as Terrence previewed, we'll have some time for questions. So first, defining produce prescriptions. So this is the Food is Medicine Summit, and so produce prescriptions are just one of several different types of food is medicine interventions. And so we have this pyramid that kind of helps you navigate what some of those other interventions look like and where they fit in relation to each other. So at the bottom of our pyramid, we have programs that focus on food security more broadly, which are really a critical foundation to supporting healthy food access generally, general population health, and prevention against the development of harmful health conditions. And so this is where we see programs that you tend to see funded through USDA, such as SNAP, formerly known as food stamps, as well as the school lunch programs. So then above this base level is where we see interventions that come into play when someone has a diet-affected health condition that food can play a role in treating and where the health system has a role to play as well. So produce prescription sits kind of on the bottom of these types of interventions because they require the least amount of tailoring for a particular condition and are generally provided to those who are still healthy enough to be able to go out and use their prescription to purchase food in a retail setting and make their own food. Some of the more intensive food as medicine interventions are those that are medically tailored, like medically tailored food packages, which you see as the next level up. And then medically tailored meals, which are designed for more acute and specific treatment needs for certain health conditions and are adapted to some of the limitations that one might have in preparing their own food. There are other interventions that have been categorized as food as medicine interventions, which include personalized nutrition education, path to purchase marketing, and nutrition incentives, which we actually will talk about a little bit more later on in this presentation as well. So that is where produce prescriptions kind of sit. And on this next slide, I just wanted to give you the definition of produce prescription program that we were working with as we put this report together. So according to the National Produce Prescription Collaborative, a produce prescription program is a medical treatment or preventative service for patients who are eligible due to a diet-related health risk or condition, food insecurity, or other documented challenges in access to nutritious food, and are referred by a healthcare provider or health insurance plan. These prescriptions are fulfilled through food retail and enable patients to access healthy produce with no added fats, sugars, or salt at low or no cost to the patient. So key elements are that in a produce prescription program, the participant becomes eligible for the prescription due to a diet-related health risk or condition, and there is some interaction with a healthcare provider or health insurance in order to receive the prescription, which then they can redeem for produce. And so while I'm not going to do a deep dive into the evidence base today, we do have a summary of some of the evidence in the report, and I'll drop a link to the report in the chat at some point today as we're talking, probably during the Q&A. And so I just wanted to note that while it continues to be a really active research space, there's already a good amount of research showing that produce prescription programs have positive impacts on several different health conditions and can be a cost-effective way for healthcare providers to address those challenges. And so that brings me to our report that I mentioned. And so the goal of this report, we had a grant that we received to work on this project for a year. It was supported by Rockefeller Foundation, and it was really to put forth recommendations for expanding access to produce prescription programs across the United States. And so to draft this report, our team went through several different stages. We first researched and analyzed the laws and policies that impact access to produce prescriptions. We then interviewed stakeholders and experts in the field to get a better sense of how these policies actually play out in the real world. And then after our interviews, we held a feedback session on our first draft of high-level recommendations to get input on the direction that we were heading in. And so as a result, we identified 5 core challenges to the expansion of produce prescription programs across the nation. So we found that funding is a key barrier, and I will note that I was I don't know.
Emma, I don't know if we can hear you. I would jump in and finish it off, but I'm not well versed on this topic.
Oh, now you're muted.
Can you guys hear me?
Yep.
All right, I'm joining with computer audio now because my phone hung up for some reason, unbeknownst that I am not aware of what happened. So hopefully this continues to work. But where I think I left off is that in our first summit session, we saw some of the research that Dr. Kafer and her team were doing, and it looked like they were seeing a lot of the same barriers with the programs that they were speaking with and working with as well. So that felt very reaffirming of the findings that we found during our interviews too. So we did find that funding was the key barrier, the lack of sustainable funding. Most current programs are grant funded, and so those, have a time limit, and they have a capped amount of money that's available, and so that was a key issue, and one we're going to dive a bit deeper into today. Additional research is needed to help make the case for healthcare payers that produce prescription programs will positively impact health outcomes, as well as to identify program design elements that lead to successful and equitably run programs. Patient data and privacy came up a lot. Any program that involves sharing patient data raises concerns about privacy and compliance with patient privacy laws. So that was an issue that came up frequently. Infrastructure was a very broad category that kind of covers the need for healthcare providers who have a level of nutrition literacy to be able to refer patients to these kinds of programs, as well as making sure that patients actually have access to retailers that are carrying the kinds of quality produce that they're looking for to redeem their prescription, and making sure, and the fact that retailers, as they're trying to participate in these programs, making sure they have the technology or access to the technology that in order to incorporate the prescription redemption into their store and transaction flow. And then finally, we heard a big call for guidance and focus in the field so that efforts at expansion are both strategic and inclusive. And so, as I mentioned, we're not going to go into the full report today because a lot of it is really focused on federal policy, but there are 20 recommendations that we made for addressing these core challenges. And so I hope that you take a look into the report. And so what we'll focus on for today are funding opportunities that I think we can really take advantage of when looking at Mississippi at the state level. So we've identified several different opportunities to expand funding for produce prescription programs. And the ones that really come into play that I think at the state level and that Mississippi can work with arise in Medicaid, Medicare, and programs that are funded through USDA. And part of the reason why we focused on these as well is because our center is more focused on on healthcare and access for folks from lower income communities. And so we did kind of have an eye on these programs as presenting the opportunities that we were looking for funding in this space. So with that, I'm going to turn it over to my colleague, Katie, to start walking us through the Medicaid and Medicare funding opportunities. And I will continue playing the slide master, Katie, so you can just tell me when you're ready to switch.
Excellent. Let's go to the next slide then. So thank you so much, Emma. As Emma mentioned, my name is Katie Garfield, and I am a clinical instructor in our center's healthcare team. And as Emma highlighted, one of the biggest barriers we heard throughout this entire process of developing this report, one back, sorry. No worries, I'll keep
Sorry,
going.
Katie, I still had my sound muted from when I was on the phone earlier, so I need to unmute that first so I can actually hear you.
Oh, yep, no problem.
Sorry about that, and I'll get this screen share up in just a second.
Okay, great. So I'll get started then though with some background. So as Emma mentioned, really the biggest barrier that got highlighted throughout our feedback session and our interviews was, of course, lack of sustainable funding for these programs. And as we were thinking through that, there's of course a couple of different areas that we can look to for funding. And the one that I'll be talking about today, of course, is the healthcare system. So given that potential impact that Emma covered very briefly, that produce prescriptions can have on health outcomes and potentially healthcare costs, it does make a lot of sense to address that gap in funding by establishing sustainable funding streams for produce prescriptions within the US healthcare system. And today I'm going to be covering some of the current opportunities to fund produce prescriptions through two of the most critical healthcare programs for low-income Americans, Medicaid and Medicare. These opportunities are discussed in more detail in the full report in recommendations 4 and 5. And I'll start with opportunities in Medicaid. And I'm sure that many people on this call are already very familiar with Medicaid and Medicare. So let me start with a brief apology to say that I'm going to give a brief overview broadly of each program before I dive in to the details on the ground for Mississippi, just to make sure that everyone's on the same page. So Medicaid is our nation's safety net health insurance program for low-income individuals. And it's run as a federal-state partnership where states design and operate their own program within a broad federal framework. So as part of this framework, federal laws and regulations establish a series of mandatory benefits that states must cover, and then optional benefits that states may cover. And while I would argue that some of these categories are broad enough to allow for the coverage of nutrition interventions like produce prescriptions, the Centers for Medicare and Medicaid Services have not explicitly agreed with that position up to this point. And so as a result, nutrition interventions are not generally covered within the standard framework of Medicaid benefits. However, as noted at the bottom of this slide, Medicaid does allow for some flexibility on this point. Both state Medicaid agencies and individual health plans that deliver Medicaid services in many states have some policy levers that they can use to provide coverage of nutrition interventions, including produce prescriptions. So let's go to the next slide. This slide outlines those policy levers, and they really fall into 3 broad categories. So we have waivers and state plan amendments, state-funded pilots, and then managed care flexibility. So flexibilities for health plans delivering Medicaid services. And I'm mostly going to focus on that managed care category today, as I think it's the area of greatest opportunity for Mississippi specifically. However, I'll give a brief overview of the other options first. So first, let's look at waivers. So state Medicaid programs can use a couple of different kinds of waivers to provide funding or coverage for nutrition interventions. And the most common waivers that we see used in this way are 1115 waivers and home and community-based service waivers. And there are also some state plan amendments that can be used for home and community-based services as well. So let's start with home and community-based services. These are waivers that allow states to provide additional services to individuals who might otherwise need an institutional level of care. So perhaps care in a nursing home or a similar type of facility. So these waivers allow the state to provide services that would allow those individuals to stay in their homes instead. And while we're not aware of any states using these waivers at this point specifically for produce prescriptions, they have historically been used to cover home delivered meals, which suggests that there is a recognition of the key role that proper nutrition can play in keeping people in their homes and communities, which may create some flexibility for use for produce prescriptions. I would note that Mississippi has 5 of these waivers, at least one of which includes meals. The other big waiver category we see in the sort of nutrition space in Medicaid are Medicaid Section 1115 demonstration waivers. This is really the broadest category of Medicaid waiver, and states use them to run 5-year demonstration projects that alter all sorts of things. They alter coverage, benefits, or payment models within their Medicaid programs to improve care. And increasingly, states are including as part of these waivers funding for interventions that address health-related social needs like food insecurity. You'll hear an example of this later today, specifically North Carolina, but we're also seeing similar efforts with Section 1115 waivers in Massachusetts, Oregon, and other states. And I would note that Mississippi currently has 2 1115 waivers, but they are focused on fairly narrow populations and services, so family planning, and then on individuals who are elderly or coping with disabilities who don't qualify for Medicaid or Medicare. So while some states, including North Carolina, that we'll hear more about, use these waivers very expansively, Mississippi up to this point appears to use them fairly narrowly. So I'm not going to focus on them as much today. And then the other big category that I just want to highlight briefly is the fact that some states are also using their appropriations process to establish pilot projects that target Medicaid populations using food as medicine services. So for example, both California and New York have used state appropriations to fund pilot projects to test the impact of providing medically tailored meals to Medicaid enrollees. And we're actually seeing a shift now in California in particular, as that pilot is closing out, to actually incorporating those meals and a broader range of food as medicine services into their upcoming Medicaid waivers. So those pilots can in some ways be an on-ramp to broader change. And then finally, let me look at the last category, which I think is the real opportunity in Mississippi, and that's managed care. So in Medicaid, state Medicaid agencies can choose to contract with private health plans like Humana or United Healthcare or others to deliver Medicaid services. Mississippi currently does this under a program called Mississippi CAN. In that program, it calls the health plans Coordinated Care Organizations, or CCOs. In other states, you'll also hear those plans referred to as Managed Care Organizations, or MCOs. And these plans must generally cover all benefits covered by the state's Medicaid program, or at least a subset of those that the state decides. But they also have the flexibility to provide additional benefits under a couple of different regulatory authorities. And you see those listed here and sort of starred. Those authorities are in lieu of services, value-added services, activities that improve healthcare quality, or incentives. And nationally, really all of those opportunities have been used to support access to nutrition interventions. So they all present opportunities to support produce prescriptions. So next slide. So now let's narrow in and look at Mississippi specifically and what's happening on the ground. As you can see, there's really some encouraging action happening in the Medicaid program across the state. So first, let's look at in lieu of services. In lieu of services are optional services approved by the state as a cost-effective substitute for a service that's already covered by the state plan. And this lever is particularly appealing because they get treated like normal Medicaid benefits. So that means that they're built into the payment the plan receives. They're treated similarly in other things like medical loss ratios. So they're very appealing from a plan perspective. So we're seeing states like California and New York experiment with using this in lieu of services authority to cover things like medically tailored meals or a broader range of food as medicine interventions either as sort of a one-to-one substitute for things like a home health worker actually preparing your meals, or in California, they're looking at it more broadly and thinking about how we can use nutrition to prevent down the line the need for things like inpatient admissions, ER visits, things like that. And I will note that in Mississippi, all 3 CCOs do have in lieu of services built into their contracts with the Division of Medicaid. However, it looks like Mississippi's use of this opportunity is fairly limited right now and really focused on mental health services. And I'll just say that's very similar to what we're seeing in a lot of states. But as I said, we're seeing states sort of creep in around the edges and expand the use of this authority. So specifically in Mississippi, plans are authorized to use in lieu of services to allow coverage of services provided in freestanding psychiatric hospitals, but we're not really seeing, at least in the contract from what I can tell, use of it beyond that. So it could be an opportunity to expand upon moving forward. In contrast, we're seeing a lot more activity around value-added services and patient incentives. So value-added services, which Mississippi seems to call enhanced benefits within its contracts, are services that are not covered by the Medicaid state plan, but which the plan chooses to voluntarily offer to its enrollees. I should note that plans typically can't include the costs of these services in the capitation amount that they receive from their state. So in some ways, they're a little less appealing than in lieu of services for that reason. Similarly, we have incentives, and incentives, just like they sound like, are services or items that the plan's offering to incentivize healthy behaviors from the enrollees. And I should note that both of these categories have to be approved under the contract by Mississippi's Division of Medicaid. And as you can see on this slide, all 3 CCOs are using incentive programs to promote healthy behaviors. For example, all 3 plans are offering gift cards or sort of prepaid MasterCards or Visa cards, things like that, to patients who take advantage of preventive services like screenings and well child visits. So there's a lot of use of this incentive structure and use of it for things that look like vouchers, right? So it's kind of encouraging from a perspective of Produce Prescriptions. Additionally, 2 plans, Molina and United Healthcare, are actually already providing coverage of fruits and vegetables through these avenues, value-added services and incentives. So they have programs known as the Farm to Table and the Farm to Fork programs. And while the plan, and I'll note that the plan materials are not 100% clear on whether or not they're seeing these as incentives or value-added services, but either way, it's highly encouraging. It suggests that the plans are really interested in understanding of the role that nutrition can play in patient health and interested in dedicating resources to addressing it. So there could be real opportunity to expand on those levers from a produce prescription perspective. And I'll go to the next slide. Oh, sorry, my little animations. There you go. So now I'm going to just shift gears a little bit to talk briefly about Medicare. And so Medicare is, of course, our nation's public health insurance program for individuals who are 65 and older, as well as certain individuals with disabilities and individuals living with end-stage renal disease or ALS. And Medicare enrollees typically receive their coverage in one of 2 ways, either through Medicare Original or Medicare Advantage. Original Medicare is the standard form of Medicare in which enrollees receive Medicare Part A, which is hospital insurance, and Medicare Part B, or medical insurance. And both of those benefits are directly coming from the federal government. And this covers about 2/3 of Medicare beneficiaries at the national level. Unfortunately, there's not really any coverage of food services like Produce Prescriptions in Original Medicare, though there's some coverage of things like nutrition counseling. In contrast, the other 1/3 of Medicare beneficiaries are enrolled in Medicare Advantage. So we'll go to the next slide. And I should note the number's a little different in Mississippi. So about 23% of Medicare enrollees in Mississippi specifically receive their coverage through Medicare Advantage. And Medicare Advantage is the version of Medicare where, like Medicaid managed care, we have individual health plans or health insurers like a Humana or an Aetna or someone else administering Medicare benefits. And again, while these plans must generally cover all benefits that would be covered in original Medicare, they also have some flexibility through what's called supplemental benefits. And these supplemental benefits are the primary opportunity historically for Medicare to address patient nutrition needs. So Medicare Advantage plans have historically had just a limited ability to cover food as a supplemental benefit. In particular, they were able to cover meals for a short duration under some narrow circumstances. However, recently, Medicare Advantage plans have been given a lot more leeway on this front through two important opportunities. These two opportunities are sort of summarized on this slide. It's special supplemental benefits for the chronically ill, which I'll describe as SSBCI, and then value-based insurance design model, which is a demonstration model through the Center for Medicare and Medicaid Innovation, and I'll call that VBID. So under the SSBCI program, all Medicare Advantage plans can now cover additional supplemental benefits specifically for chronically ill enrollees. And those are individuals who have one or more comorbid medically complex chronic conditions that are a high risk of hospitalization, or other adverse health outcomes and require intensive care coordination. And so for this population, this sicker population, CMS has explicitly stated that Medicare Advantage plans can provide additional supplemental benefits as long as they have a reasonable expectation of improving or maintaining health or overall function. And CMS within guidance has noted that that can include food and produce. So this is a real opportunity through SSBCI to provide funding for produce prescriptions. And then the second opportunity on this slide is, as I said, a demonstration model called VBID that's run through the National Center for Medicare and Medicaid Innovation. Plans have to individually apply to participate in this model, but if approved, they again have additional flexibilities to design their benefit packages to encourage patients to use high value care. And one of those flexibilities is an opportunity to offer additional supplemental benefits. So like SSBCI, these additional supplemental benefits can be pretty broad. They don't have to be primarily health related. And CMS has said they can include things like food and produce. And the big difference between these two opportunities, well, actually two big differences. One of them is that SSBCI is sort of universally available to Medicare Advantage plans, and VBID is an application process and you have to be approved. But the other big difference is how they can be targeted. So as I said before, SSBCI really focuses on chronically ill individuals, whereas the VBID model provides a little bit more flexibility. Plans can target that based on chronic condition, socioeconomic status, or a combination of both. And so on this slide, you can just see briefly a mention of what does this mean for Mississippi. So of course, we said about 23% of Mississippi Medicare enrollees are in Medicare Advantage plans. And so those Medicare Advantage plans can take advantage of the SSBCI opportunity to serve chronically ill individuals. And then, as I said, on the VBID side, that's an application process, but we know that there are at least 2 plans that are currently involved in VBID that are operating in Mississippi. So through Humana and the United Health Group, both of those groups are participating in the VBID model, though there's not a lot of information available on exactly how they're targeting their benefits within that model right now. So not a lot of information available on whether they are currently using it to offer food or produce, but they could. So that's sort of a potential opportunity moving forward. So next slide. And so before I hand things over, one thing I just wanted to close out as we think about these healthcare opportunities with just a couple of key considerations that tend to come up as we see organizations that provide nutrition interventions starting to really partner with the healthcare system. First, I want to highlight that there's a lot of competition for these funds. While these flexibilities in Medicaid managed care and Medicare Advantage programs can be used for food and produce, they can also be used for a whole bunch of other sort of health-related social needs. So there is competition for these funds and sort of a limited pool of funding. There's also some common contracting hurdles to be aware of. So things like, if you have a produce prescription program, do you have the capacity to meet plan needs? So for example, can you serve their entire service area, or is there going to be a need to find other ways to cover that, that entire region? Second, one that Emma mentioned earlier, which is patient privacy. As we see new partnerships between the social service sector and the healthcare sector, we often see questions come up around the application of HIPAA and state patient privacy laws in those contexts. And so it can be a bit of a hurdle that needs to be worked through with attorneys or others to think through, how do you set up the systems and infrastructure needed to protect patient privacy. Third, sometimes we see insurance coverage around liability for things like HIPAA come up. So are the produce prescription programs, do they have that sort of insurance coverage in place? And then finally, also thinking about the policies and procedures that health plans and healthcare providers often need to think about, like quality assurance and improvement policies and procedures oftentimes are required. So thinking about whether or not those are in place or could be set up within produce prescription programs. So a lot of great opportunities out there, but also some key considerations to keep in mind. So I'll now go ahead and turn things back over to Emma.
Great, thanks so much, Katie. So now I'm going to turn back to these funding opportunities and shift the focus to what's available in USDA. So one of the things that we wanted to highlight in our report and really draw out is the fact that there actually is already a federally sponsored produce prescription program, which is WIC. And so we don't usually talk about WIC like a produce prescription program, but if you think back to kind of the way that we define a produce prescription program, WIC already operates in exactly that way. So in Mississippi, you would have an individual who may be eligible for WIC or seeking to enroll in WIC would meet with a healthcare provider, which could be a nurse or a nutritionist, who determines whether that individual qualifies for WIC based on their medical or nutritional risk, as well as some income guidelines. So there is that interface with a healthcare provider. And then if they do enroll in WIC, they'll receive one of the available packages. And if they're a child or an adult in the program, then part of that package will include a cash value voucher or a cash value benefit that provides a certain amount of money each month for the purchase of fruits and vegetables. So for children, at least the federal level is set at $9 a month. And the level for adults is set at $11 a month, although there was a recent temporary increase that I'll mention in a moment. So we know in Mississippi, WIC participation for the past year was just over 77,000 individuals. And WIC has also been in a big transition period. So moving from having folks go to warehouses to pick up the items that are in their WIC package to using eWIC or an electronic EBT card in retail stores to purchase their WIC items instead. So Mississippi really is kind of in the very middle of going through this transition. According to the state's website, there are a lot of counties in the Delta region who are supposed to be making that transition to retail this month and as well as in May. And so that means that even more so, we'll see this operating like a produce prescription program because folks will be going into the retail setting in order to redeem the voucher that they've received through the WIC program. And so part of the reason I wanted to highlight this is because WIC offers an opportunity to build on a structure that's already in place. So we've seen programs implemented across in other areas of the country that sort of piggyback on WIC and offer an additional produce prescription on top of the WIC amount in order to target pregnant individuals or children and increase their purchasing power with respect to fruits and vegetables. And so that's an opportunity that, that folks in Mississippi could take advantage of as well. There's also, I think, an opportunity to think about ways to leverage the purchasing power that's channeled through WIC. States are permitted to authorize the use of this voucher at farmers markets, but based on what I reviewed, the state's materials, it doesn't look like Mississippi has authorized farmers markets to accept EWIC yet, which makes sense since it's really a brand new program for at least the EWIC portion of it for Mississippi. And so I think as we're seeing how this kind of rolls out in the retail setting, really encouraging the state or the Department of Health to approve farmers markets to be able to accept these benefits as well, so that some of those WIC dollars that are being used to purchase fruits and vegetables can be used for the local economy and supporting local producers as well. And then the last thing I wanted to mention is that in the American Rescue Plan, there was an approved increase to $35 for the cash value benefit for both children and adults in the program. But that is at the state's option. And so the USDA just put out guidance, I think 2 weeks ago, on states getting approval for that. But that's something I think we want to watch out for. And if Mississippi doesn't seem like it's ready to do it straight out the gate, I would urge folks to put some pressure on the Department of Health to make sure that those federal dollars are available to WIC participants in the state as well. And so I just wanted to shout out, I mentioned that some programs have built on WIC in order to administer their produce prescription program. And so this is just one example of a program. It's called Vouchers for Veggies, and it's run in California in the San Francisco area, although they've recently expanded to other locations. And the program worked with their local county WIC office to distribute an additional $40 in produce vouchers for pregnant WIC clients for a period of 6 months. And then through a partnership with UC San Francisco, they have studied the outcomes from this program and have found in their preliminary findings that the folks who received the increased produce prescription increased their fruit and vegetable intake. It improved food security, and it reduced the odds of preterm birth. Which is estimated for each preterm birth, it saves approximately $65,000 in healthcare costs. So that's really exciting. This was just, their study was just published, I think earlier this year, either in December or January. So very recent. And it's really exciting to see produce prescription programs that kind of use a structure that's already in place with WIC to build out their own program. And then I also want to mention too, even though we were talking about sustainable funding opportunities and not so much grant opportunities, there are some really important grant opportunities that are available through USDA. And that's through the Gus Schumacher Nutrition Incentive Program. So GusNIP it's called GusNIP for short, has a big pool of funding and a grant program that runs through NIFA, the National Institute of Food and Agriculture. And they're working with about $40 to $45 million each year for grants under the program. So there are really two main categories of grants. The first is for nutrition incentive programs. And these programs are SNAP based. So you have someone who's enrolled in and using SNAP who is able to go to a retail location and use their SNAP dollars to earn additional incentive dollars when they spend their SNAP benefit on fruits and vegetables. So it's both to incentivize the purchase of fruits and vegetables with SNAP dollars, and it gives extra dollars on top of what their regular allotment is for the purchase of additional fruits and vegetables. There are three types of grant tiers within this program. There are pilot projects, standard projects, and large scale projects with time spans ranging from 1 year to 4 years, and funds available from $100,000 to over $500,000. But I will note that there is a match requirement. So a dollar for dollar basis for every dollar of the grant, you have to have raised $1 more in your own funding. And in a moment, I'll talk a little bit about a project that already exists in Mississippi that takes advantage of this opportunity. The second pool of funding is for produce prescription programs specifically. So this is a relatively new pool of funding that came about with the last Farm Bill. And about 10% of the GusNIP dollars are reserved for this program. So this year, there's going to be about $4.8 million available for produce prescription program grants. So with these programs, the folks who are eligible to participate can either be SNAP eligible individuals or enrolled in Medicaid. And the program itself needs to partner with a healthcare provider, but there is no match required for this program. So the grants themselves are $500,000 for up to 3 years. And so I'm going to mention the nutrition incentive program that we already have here in Mississippi. And I think I saw the program director come in a little while ago. So I know that she's here, and I'm hopeful that at some point at the as a part of this summit, we'll get to hear a little bit more from her in detail about how she's running the program and how it's going. But I did want to include nutrition incentive programs because even though they're not technically a produce prescription program in the way that we're defining them, they're still a really important food as medicine intervention, and they're increasing the ability of folks to be able to purchase produce, which is important for general population health, but also it's really important for sort of having an off-ramp for those who may be enrolled in a produce prescription program. And then when that program comes to an end, having something on the other side of it that ensures that they're still able to access the produce that they need for maintaining their health. So I know we're crowding up on time a little bit, so I'll just go over this very briefly. And as I mentioned, the program director, Erin Smith, I'm hoping that she'll be able to talk about this in more detail at some point. But she was able to receive a GusNIP grant for a large scale project of $841,000. And she successfully raised matching funds so that the project has $1.68 million for a program that's going to run through November of 2022. The project really launched, I think, toward the beginning of this past year, which means that that they were getting off the ground right as the pandemic hit, which of course I think running one of these programs is challenging enough, but that of course set some roadblocks or some hurdles to getting things up and running. But it's, from what I can tell, it's been really successful, and there are a couple locations located in the Delta. So we have a Bowles Marketplace in Cleveland, and then the North Bolivar County Market, which is a mobile market with Delta Fresh Foods that moves around the county. And so both of those locations, folks are able to use their SNAP dollars and get those incentives for produce. And also, although it's not quite in the Delta, since it's not too far away, I wanted to mention it's also available at the Hernando Farmers Market.
This is Erin Smith. I'd like to talk about my program. I didn't really know we were going to be highlighting that today. So I do want to just give my Delta area people some exciting news. We have recently, as of May 1st, we'll be tripling our footprint across the state of Mississippi. So we'll go from 10 sites to 30. And so we have some exciting new stores. We'll have the Turner's Market in Indianola that will be running the program, all the Vowel stores. So there'll be a few more Delta area stores, and we're working really hard, or I'm working really hard to try to get more vendors in the Delta and the Northeast Mississippi all the time. So this weekend, our website will be under construction, and we should go live with our new website with a new map. I have new flyers that show the 30 locations we're in across the state. So we're working hard to increase the footprint for all SNAP recipients across the state of Mississippi.
Thank you so much, Erin, and thank you so much for the incredible leadership that,
thank you, Emma.
Launching this and expanding it so quickly, even in the midst of a pandemic. It's incredibly impressive what you've been able to do with the program. And I'm really excited that you're here and able to share that news with everyone. And so the last thing I wanted to mention too was just that there was a produce prescription program grant that was awarded to the Delta Health Alliance's Delta Eats initiative to launch a produce prescription project under GusNIP as well. That was just announced in fall of 2020, and so I don't have any additional details to share, but that's another project that I'm hoping as part of the Food is Medicine Summit that we're able to highlight at another time. And so that is all for me, and I would love to turn it over to Bridget to share a little bit about what is happening in another state that could serve as a model for things Mississippi could do.
Yes, thank you, Emma. So just to briefly reintroduce myself, I'm Bridget Slater. I'm a student with the Food Law and Policy Clinic, and I'll be talking about what's happening in North Carolina. So I'll give an overview of what's happening in North Carolina as an example of how different states and community-based organizations can leverage opportunities to both provide produce prescriptions and also to increase produce purchasing power. So North Carolina is an interesting example because they're combining many different opportunities to reach folks. So the state has a 115 waiver that got approved by CMS, and this allows them to launch their Healthy Opportunities pilots. Some other activities going on there. So the community organization Reinvestment Partners offers several different produce prescription programs. And then North Carolina also has a number of other nutrition incentive programs. So for example, Double Up Food Bucks and Fresh Bucks. So I'll speak about the nutrition incentive programs first. So we just heard about Double Up Food Bucks in Mississippi. It's also happening in North Carolina. Mountain Wise and Macon County Public Health have formed a public-private healthcare partnership that runs this nutrition incentives program. Mountain Wise works with the 8 westernmost counties of North Carolina to provide access to local fruits and vegetables, provide opportunities for physical activity, and also to access services for chronic disease management. In 2019, Mountain Wise received about a $380,000 GusNIP grant. And overall, this is a matching program. So we know that for $1 spent on local produce using your SNAP EBT card at a participating store, then participants are able to get $1 worth of free produce, and that this matching benefit ends up getting capped at $20 per customer per day. Another nutrition incentive program is Fresh Bucks. This is run by RAFI USA. So RAFI stands for Rural Advancement Foundation International, and it's based out of Pittsboro, North Carolina. The program's goals are to increase the number and type of local food markets served, and they use innovative SNAP outreach strategies to increase SNAP shopper attendance and fruit and vegetable purchases. In 2015, through a partnership with the Kate B. Reynolds Charitable Trust, RAFI USA launched the Fresh Bucks Consumer Incentive Program, and this allows the doubling of buying power of EBT shoppers at participating farmers markets. In 2016 and 2017, they expanded into more markets. So more markets joined the Fresh Bucks program, and returning markets also saw dramatic growth. And then in 2019, RAFI USA expanded their Fresh Bucks program further through funding from USDA's FENE program, which is now called GusNIP. So this program operates very similarly to the Double Up Food Bucks program, but it's specifically focused on farmers markets. So FreshBucks tokens are extra market dollars for SNAP/EBT users, and they can spend these on fresh fruits and vegetables at the farmer's market. For each dollar a SNAP user withdraws from their account to spend at the market, they'll be matched an additional $1. And again, this is also capped at a total of $20 of FreshBucks. Notably, the FreshBucks tokens do not expire until the end of the market season. And if a customer does not use all of their tokens in one day, they can bring them back at their next visit. So although Rafi is only able to partner with 12 to 15 local markets each year to offer this FreshBucks program, they also help markets assess other strategies to help increase food access for customers. So they additionally provide technical assistance where they can help with accessing SNAP or EBT at a farmer's market. They can provide advice about point of sale terminal equipment options, helping build market capacity, fundraising and sponsorship opportunities, or other food access strategies. So next I'll be talking about the Section 15 waiver, the Section 1115 waiver, and also what Reinvestment Partners is doing. And for this, we can transition to the next slide where I'll go into those in more detail. So the Healthy Opportunities Pilot is part of the Section 1115 waiver. In October 2018, CMS approved North Carolina's 1115 waiver for a 5-year demonstration period. This waiver gave North Carolina's Health and Human Services Department the ability to transition from a fee-for-service delivery system to a managed care program. So through the Healthy Opportunities Pilot, they'll launch in 2 to 4 geographic areas of the state to help test evidence-based interventions that are designed to reduce costs and improve health by more intensely addressing issues like housing instability, transportation insecurity, food insecurity, interpersonal violence, and toxic stress for eligible Medicaid beneficiaries. Under this waiver, North Carolina's Medicaid managed care plans, which are called prepaid health plans, or PHPs for short, will be responsible for identifying eligible beneficiaries, assessing them for needed services, managing the pilot budget, and collecting and submitting data. And then on the pilot facilitation side, LPEs, which stands for lead pilot entities, will convene the key pilot entities. So that includes the prepaid health plans that I mentioned earlier, along with human services organizations and clinical leaders, as well as other stakeholders, to promote communication and coordination across all partners. And for the LPE, some of their key responsibilities include developing a human services organization network, convening some of the key pilot stakeholders, paying the human services organizations, and providing financial oversight. And they also provide technical assistance and also collect and submit data. So to look at what a community-based organization in North Carolina is doing, we can look at Reinvestment Partners. So their aim is to foster healthy and just communities by empowering people, improving access, and shaping policy. And they offer a number of different produce prescription programs. Collectively across these programs, they're operating in about 200 Food Lion stores and reaching about 40 counties in North Carolina. So in order to be eligible to participate in one of Reinvestment Partners' produce prescription programs, participants have to be registered patients of the participating clinics. They have to be an active SNAP beneficiary, and they have to be receiving care for a targeted clinical condition. So the enrollment process consists of a SNAP participant visiting their healthcare provider. That provider then enrolls them electronically, and then they get $40 per month for fruits and vegetables on their Food Lion customer loyalty or coupon card. And some of the funding sources for these Reinvestment Partners produce prescription programs include USDA, Blue Cross Blue Shield North Carolina, the Rockefeller Foundation, and also many other partnering organizations. So some of the specific programs, one is called Super SNAP. They recently received a $1 million GusNIP grant award in 2018 for the Super SNAP program. And Super SNAP is a partnership between Reinvestment Partners, Food Lion, and FQHCs, which are federally qualified health centers, and county health departments. So they all work in partnership together. And these local FQHCs and public health departments will refer participants to Super SNAP and also help provide wraparound services to clients with nutritional needs. Another program is Bull City Bucks, which is very similar to Super SNAP, but it's specifically for Durham County. And they last received a $400,000 GusNIP grant in 2017. But more recent grant award activity that Reinvestment Partners received was getting a 507 GusNIP grant award in 2019, which will last for the next 3 years. So that'll end in 2022. And then one of their most recent programs, which they got money for in 2020, they recently launched their Reinvestment Partners Produce Prescription VA program, which provides low-income Durham Veterans Affairs patients who receive SNAP benefits with a monthly produce prescription to purchase fruits and vegetables from Food Lion. And this program is unique because it specifically focuses on veterans, and it partners with the Durham VA to refer participants and provide wraparound services. And so this award they got in 2020 will last for 3 years. It's a GusNIP grant for $500,000. And so just, what we've seen from this example that North Carolina is using nutrition incentives, produce prescription programs, their Healthy Opportunities pilot, which was made possible by the 1115 waiver. We've just seen that North Carolina has really diversified its opportunities to improve access to healthy produce and also enhance produce purchasing power. And so although when you look at an example that another state is doing, nothing is ever exactly copy and paste, but we do think that this example could spark some ideas for Mississippi. And for that, I'll hand it back to Emma for the final portion of the presentation.
Sure, thanks so much, Bridget. And so I think really for the final portion of the presentation, I just wanted to remind everyone that that in our recommendations, we do kind of do a deeper dive on those 5 core areas or challenges that we identified through our conversations with stakeholders, and really kind of get into the weeds. But in the interest of time, I think at this point it would probably be best to turn to some questions. And so Katie and I, and I'm sure Bridget too, are here and happy to answer any questions you might have.
All right, another Food is Medicine Summit in the books. A lot of great information that was just received by everyone on this call. So I'm hoping we have a lot of questions prepared. And I'll start off with one. Being from Mississippi, I think we all know someone that has a garden in their backyard or has a garden in their backyard. And so we know the direct benefits of switching to a food prescription program, but what are some of the economic advantages for a state like Mississippi to, what kind of economic advantages would they receive if they did switch over to a more robust food prescription program?
Yeah, I think I'll put another report if I can find it in time while we're in the Q&A and the chat, because while we were drafting this report, a great study came out from Colorado State University that was looking at the economic impacts of nutrition incentive programs. And so we're thinking about this money that's coming from a lot of it coming from USDA, but also from foundations and fundraising efforts that are going into these programs and putting that money, back into the communities, particularly when folks like I can see, obviously Erin's been doing, are working with the stores and the retail locations that have been longstanding pillars in the community. And so channeling that money, produce prescriptions are an opportunity, as particularly if they're supported by insurance companies and by these larger healthcare payers, of putting some of those healthcare dollars into the local economy. And so I think it offers a lot of great opportunities for supporting local retail establishments, but also farmers markets and local producers when they're able to be used in coordination with farmers markets as well.
Absolutely. I think we have some politicians that might need to read the report that you were referring to, so we can switch over. I see one question from Dr. Annie Kafer. So she says these are all amazing programs, and their program is on target. She wanted to know if you all could speak to the evaluation of the impact of these programs. Specifically, do these programs assess whether they move the needle on health outcomes, basically?
Sure, I'm happy to chat a little bit about that. So there is sort of an emerging research body around the impact of produce prescriptions on health. And I will say, I think we're going to know even more in this space over the next couple of years through evaluations coming out of programs like GusNIP, as well as a number of grant-funded programs. We know that Rockefeller has funded further research in this space. So I think we're going to continue to know more and more specifically about health impacts over the next few years. But of the studies that have come out, we've seen improvements, particularly around things like hemoglobin A1C, and particularly across the board, pretty much impacts, of course, on diet and consumption of healthy fruits and vegetables, and impact decreasing food insecurity. But beyond that, we have seen these health impacts like reducing hemoglobin A1C. At least one pilot study noted improvements in blood pressure, and some of the studies have also looked at things like BMI, decreases in depressive symptoms, and improved patient-provider relationships. So I will say there is some initial research that is growing at this point. In the introduction section of our report, we provide a table of some of the peer-reviewed research that is available in this space up to this point. There was also a great review study that came out over the last year that looked at some of these pieces as well, that I can try and drop into the chat, that also talks about the pilot studies that are out there around health impacts.
Right. We have another question from Tom Pittman. In our last Food is Medicine Summit, Dr. Scott Morris, he talked about making produce usable to patients, and kind of how they can prepare it and cook it to adapt to their new diet. And he wants to know, are there any states doing anything about food preparation and cooking education? And does that, and I'll add to that, like, does that fit into that same model that you were referring to? I think it was a pyramid that you all referred to in the beginning, where it showed the different levels of food as medicine model, and seeing how they can kind of correlate.
So I would note that nutrition education, and sometimes including things around preparation and cooking, is a component of many of these produce prescription programs. I will say that not all of them. There are some programs that specifically just focus on the provision of produce, but there are a number of programs across the country that include nutrition education as a core component. And very soon, hopefully, there's going to be a field scan coming out from a group called DIESA that actually looked at all of the programs across the country over about the last 10 years that describe themselves as produce prescription programs, to assess these types of things, like what percentage of them provide nutrition education and things like that. So again, we're going to have a much deeper understanding of the proportion of programs that include that, I think, in the next couple of months when that comes out. But I know anecdotally from the programs that we spoke to, many of them do include nutrition education.
Okay. And we have another question from Brenda. I know, Emma, you placed a link in the chat kind of addressing her question about whether is there a list of the participating food markets in the Double Bucks program? And I know you wanted to defer to Erin to see if she had any update or anything that she wanted to say about that
question. Yes, again, Double Up locations, we've expanded to 30 new markets. The flyer and the map will be updated per our website this weekend. Please go there, fill out any vendor request forms. A lot of people get confused on this program, although we're all in the same, we're all listening intently right now, but we forget, if your farmer's market is not a centralized EBT, does not take EBT or SNAP, you do not qualify for the program. It is a SNAP program through the USDA. And with when I ran Fresh Savings, which was a Finney grant, when the new RFA came out for GusNIP requirements through the Farm Bill of 2018, there was an added layer or barrier really for grantees that wanted to have just particular farmers run their program. Technically, you can be a farmer and be a double up vendor. The however to that is, if you are at a farmer's market, each farmer's market needs to be a centralized EBT, which means if, like Gia does it in Hernando, she works with farmers that have their own EBT abilities to take EBT, but she as a market has decided when you're selling your produce at that market, you are going to allow the customers to go to the centralized location at the Hernando Farmers Market, swipe your EBT there, get your incentive double up tokens, and then go shopping. So it's not, there's a lot of hoops that you have to go through as a direct farmer. So if you are a manager of a farmer's market and you want to be on the double up program, you have to be a centralized location accepting SNAP/EBT. I know that's if you don't already accept EBT or SNAP, then that might have been a really confusing set of sentences, and I apologize. But like I said, the update to the website is coming because we do launch in 30 places across the state May 1st. We do have farmers markets, produce stands, grocery stores. And once that double up site is up and running again, there is a VIP form. If you're a nonprofit and just want information about our program, you would fill that out. If you want to be a vendor, if you accept SNAP and sell produce, you want to be looked at for a vendor, there's also a place there where you can fill that form out. I hope that helped.
Absolutely. Do we have any other questions for the presenters? I'm taking it we have none. Okay. All right. So I just want to thank you all again, Emma, Bridget, and Katie. Great information. I hope people can walk away with something very useful. I'm sure they will. And I don't know if you all are going to be providing anything that any one sheet, is any information that we can send to the participants on the information that you just presented on. I'll be glad to send it out to everyone. But thank you again. Thank you everyone else for coming to our third summit. And so just as an update, we're not going to have a Food is Medicine Summit in May. Because we just had 2 this past month. We don't want to overload you again, but we are going to double back again in June and have 2 summits, and we'll keep you updated on those sessions. And whenever we get more information from Emma and this team about any deliverables, we'll also get that out to you. So I hope everyone enjoys their weekend, and we look forward to seeing you all again.
Thank you. Happy weekend.